So now we are going to discuss in this series the autonomic system, nervous system, the sympathetic nervous system part. So let's discuss the effects of sympathomimetic versus sympatholytic drugs on different organ systems. So first, it is the eye, and in the eye, we should know that the receptors which are present in the eye, in the radial muscles, we have the alpha 1 receptors. Radial muscles, okay. So in the radial muscles, we have the alpha 1 receptors, and when you stimulate these receptors, there is going to be mydriasis, which is called as active mydriasis. But on the other hand, on the circular muscles, we have M3 receptors. So in case you block the alpha 1 receptors, there's going to be unopposed action of M3 receptor, which is going to cause meiosis. But that meiosis is called as passive meiosis. Alright, so active mydriasis, which are the drugs which can cause this and we are using them therapeutically? So we have phenylephrine. Phenylephrine, okay. So this phenylephrine is going to cause mydriasis. So we can use this in fundus examination for the testing of the refractory errors. And we are going to then alternate that with a meiotic. So alternate with meiotic for uveitis. So alternating with a uveitis, with meiotic for uveitis. So these are the various uses of phenylephrine. And remember that any mydriatic drug should not be used in people who have glaucoma. So contraindicated in glaucoma patients. On the other hand, the sympatholytic effect like meiosis, we don't have any particular use here for these drugs. On the respiratory system, we have the beta 2 receptors. These are very, very important. So when they are stimulated, they lead to bronchodilation, while the opposite, when you oppose them or when you block these receptors, they lead to bronchoconstriction. So in bronchodilation, we have beta 2 agonists. We have specific beta 2 agonists here. So we have short acting beta agonists. For example, we have salbutamol, we have terbutaline. Then we have long acting beta 2 agonists like formoterol and salmeterol. Then we have very long acting beta 2 agonists like olodactyrol. Right? So these are all the beta agonists, short acting, long acting, very long acting. So remember one of these drugs, which is formoterol. What is the advantage of this drug? It has become the beta 2 agonist of choice during the acute attack. Why? Because not only it is long acting, but in contrast to salmeterol, this also has a quick onset of action. So it has a quick onset of action. So both these things are good for us. Quick onset of action, and it has a long duration as well. So we don't have to repeat it again and again. Right? So these are the important beta 2 agonists. Bronchoconstriction definitely is not a desired thing, so we have no use here. Then on the heart, we have beta 1 receptors. So when beta 1 receptors, they are stimulated, they will lead to increase in the heart rate, in the force of contraction, as well as the conduction. So here we have a drug which is called as adrenaline. So adrenaline is a drug which we use for this purpose in case of cardiac arrest, right? So in cardiac arrest, and this can be given in 1:10,000 concentration IV in the jugular vein. Decrease in the force of contraction would be the opposite effect when we block them. So decrease in the heart rate, force of contraction, as well as the conduction. So what is the use here? We use beta blockers, right? So beta blockers are very important drugs in cardiovascular system. So we use effect, you want to decrease the heart rate or you want to decrease the conduction velocity. Where do you think that will be good for us? In case of fibrillations, especially AFib, atrial fibrillations or atrial flutter, because we don't want these conductions to be passed on to the ventricles, so we want to prevent the ventricular fibrillations. Then number 2, this is used in case of chronic heart failure, but not in acute heart failure or in chronic heart failure. And you can also say this is compensated, or in other words, we can say it's a compensated heart failure. In low doses we use here. Then it can be used in hypertrophic obstructive cardiomyopathy. Then it is used in case of aortic dissection. So these are the uses of beta blockers according to on the heart, on the organ system. On the blood vessels, we know blood vessels are predominantly dominated by the sympathetic tone, right? So we have alpha or the beta receptors here. So remember a trick here. So this is your blood vessel. So we have either alpha 1 or stimulation would be beta 2. So beta 2 stimulation leads to vasodilatation, alpha 1 stimulation leads to vasoconstriction, right? So remember the simple rule A, B, C and D. That means when you stimulate the alpha receptors, it causes constriction. When you stimulate the beta receptors, it causes dilatation. Simple trick to remember. So beta 2 receptors, actually they are more sensitive. So when you have a smaller dose of the drug of the sympathomimetic like adrenaline given a smaller dose, then mostly this beta 2 effect will be seen. So even in the body as says endogenously, the beta 2 effect is always more predominant. But when you give a high dose of adrenaline, then even alpha 2 receptors, they are stimulated. And the predominant action would be because of alpha 1, that is vasoconstriction, right? Alright, so let's see the uses of this. Now, first drug here I want to tell you about is phenylephrine. So let's talk about the drug which is phenylephrine. Phenylephrine is a drug which only acts on the alpha 1 receptor. It has no beta action, yeah? So on the alpha 1, when it is stimulated, there is going to be vasoconstriction. So where do you think we can use it? It is used in case of hypotension due to spinal anesthesia. So postural hypotension due to spinal anesthesia. Similarly, we have another drug that is called as metodrine. So this is the drug of choice for postural hypotension. Postural hypotension. The third drug we have is norepinephrine or noradrenaline. Now this is the drug of choice for neurogenic shock. Neurogenic shock for cardiogenic shock and for septic shock. Alright. Now, then we have adrenaline or the epinephrine. So, it is the drug of choice. Where is epinephrine the drug of choice? Yes, it is the drug of choice for anaphylactic shock. So, it is used in anaphylactic shock, where it has both the beneficial effects due to alpha 1 also as well as due to beta 2. Right? So, alpha 1 action will bring about vasoconstriction. It will increase the blood pressure. It is also helpful in case of to decrease the laryngeal edema. Okay. And beta 2 effects is going to bring about bronchodilation. Alright. Moving on to the other end, which is the sympatholytic effect. So, where do you think can we use the sympatholytic drugs here? So, for example, first we'll start with the blockers. Here we have very, very important drug which is called as phenoxybenzamine. Now, phenoxybenzamine is an irreversible alpha blocker and it is a non-selective blocker. Okay. So, irreversible alpha blocker, it has a very long duration of action because of this. So, where do you think we can use this? This is used to bring down the blood pressure when we have put a patient up. Pheochromocytoma is a tumor and we want to resect the tumor. But before we do the resection, the surgery, we have to bring down the high blood pressure. So to bring down preoperatively that high blood pressure, we give phenoxybenzamine. It has a long duration of action, that's why. So preoperative treatment of hypertension in pheochromocytoma, right? All right. Number 2, we have another drug, phentolamine, which is also an alpha blocker like phenoxybenzamine, non-selective, but it is a reversible blocker. It is short duration. It doesn't have a long duration, short acting. So here we can use during the surgery of when we're doing the surgery for pheochromocytoma in case of spillage of the catecholamine, when there can be a risk of high blood pressure again rising. So what we do during the surgery to manage the intraoperative hypertension, we can give this drug. So this is for treatment of intraoperative hypertension in pheochromocytoma. Pheochromocytoma. Okay. Number 3, or let's say another use of phentolamine can be during the hypertensive emergencies, like in case of clonidine withdrawal or in case of cheese reaction. All right. Number 3, we have selective alpha blocker like prazosin. It can be used in case when there is benign hypertrophy of prostate along with hypertension. If there's only benign hypertrophy of prostate, then you will give selective drugs like tamsulosin or silodosin. But if there is hypertension also alongside, then we would prefer to give a drug like prazosin because it acts on both alpha 1A and alpha 1B. So alpha 1B is the area where it takes care for hypertension. Only if you want to treat the BPH part, then only this alpha 1A would be sufficient. So for this, we have drugs like tamsulosin. Okay. So only alpha 1A we have here for tamsulosin. All right. Moving on to the next, we have beta blockers also. Again, they can be used in management of hypertension, right? So the beta blockers. So these are the important uses when we talk about the blood vessels as a target. Then skeletal muscles. Now skeletal muscles, they have beta 2 receptors, and when you stimulate these receptors, they bring about tremors, right? Because of the contraction. So tremors is an important adverse effect with especially beta 2, one of the most common and important adverse effect beta 2 agonists, because they're going to stimulate this. So sympathetic is blocking the contraction. So when you give beta blockers, they can treat the tremors. Okay, they can treat the tremors. Then smooth muscles on the uterus or on the bladder. So they bring about relaxation of the muscles, whether it's beta 2, beta 3, right? So the bladder sphincter contraction is because of alpha. That's why I told you when we use an alpha 1 blocker, they can be used in case of the benign hypertrophy of prostate here. So first let's do the sympathomimetic effect. So we have beta 2 agonists. So we have beta 2 agonists like ritodrine. So this drug especially, not very common, but yes, it can be used in case of to delay premature labor. Because it will relax the uterine muscle. So to delay the premature labor. Then we have beta 3 agonists, very important drug group like mirabegron. So this is used because it brings about relaxation. So in case of overactive bladder, we can use them. So use is overactive bladder. So it is very preferred these days for overactive bladder. The other drugs we use for overactive bladder are your anticholinergics also, like the 5 dots if you remember. But this is a preferred drug because doesn't have a side effect like causing dementia by crossing the blood-brain barrier. All right, so this is the use here. Now in the blocker section, you can say the alpha 1 blocker, right? Like tamsulosin or silodosin. So these are specific alpha 1A blocker. Silodosin. So they can be used in benign hypertrophy of prostate. But as I told you already, alpha 1A plus alpha 1B blocker. This is your prazosin, doxazosin, etc. This is used when we have to treat benign hypertrophy of prostate along with hypertension. Moving on to the next very important graph. So this is a graph which shows you the effect of these various sympathomimetic drugs or catecholamines on the blood pressure. So effect on the blood pressure and heart rate, rather the reflex heart rate I'm talking about here, okay? So moving on to the first drug that we have is norepinephrine. So you can be asked to identify the graph which catecholamine is showing this effect. So norepinephrine, you know that, always remember, this norepinephrine acts on alpha 1, alpha 2, beta 1, and it has no effect on the beta 2. So there is no beta 2 effect. And epinephrine, or the other name is adrenaline, right? Adrenaline. Remember, adrenaline starts with an A. So A means all. It acts on all the receptors. Alpha 1, alpha 2, beta 1, beta 2, beta 3. And noradrenaline means Na. That means it doesn't act on all the receptors. Therefore, beta 2 is excluded. Isoproterenol is only active on the beta, acts only on the beta receptors. No alpha action here. No alpha action. So, norepinephrine, by acting on the beta 1 receptors on the heart, it's going to increase the systolic blood pressure. So, this is the systolic blood pressure. So this is due to the effect on the blood vessels. Remember, ABCD rule. Whenever alpha receptors are stimulated, what do they cause? They cause vasoconstriction, right? So we are going to see an increase in the diastolic blood pressure because it had no effect on the beta 2. So only we see the increase in the diastolic blood pressure. So what will happen to the mean arterial pressure or the MAP? It is going to rise. So there's an increase in the mean arterial pressure. Now always remember, whenever you see the diastolic blood pressure, whether it is falling or rising. So whenever in the systemic circulation there is fall in the BP, so there is going to be a reflex action on the heart. And always a trick to remember is this heart rate, the reflex heart rate will always be opposite to the diastolic blood pressure. So if the diastolic blood pressure is rising, the reflex heart rate would definitely go down. So that's why there is reflex bradycardia. Okay, so moving on to the epinephrine. Now epinephrine, similar effect because of the action on the beta 1 receptors. But on the blood vessels, it has action on both beta 2 as well as the alpha 1. But I told you that endogenously, when we are not giving it from outside, when it's in normal concentration in the body, it acts on the beta 2 more as compared to the alpha 1 because beta 2 receptors are more sensitive. So the predominant effect is going to be of the beta 2 receptors. And when beta 2 is stimulated, ABCD, it is going to lead to vasodilatation, which means fall in the blood pressure. So the diastolic blood pressure is going to fall. So when we find out the mean, the rise in BP is more as compared to the fall in the BP. So ultimately, the mean blood pressure does rise, but not as much as is seen with noradrenaline. Now, what happens to the reflex heart rate? We only have to see the diastolic blood pressure. The diastolic blood pressure is falling, so reflex heart rate automatically will go up. So there is reflex tachycardia. Okay. Now, coming to isoproterenol. Again, same thing. Here, beta 1 receptors, there is increase in the systolic. But diastolic, you see, there is no alpha 1 action. Right? So, there's only beta 2 action. So, beta 2 is going to lead to drastic fall in the blood pressure. So, the diastolic blood pressure is falling here. And Again, the heart rate, we have to see it should be opposite because the fall is so much that there is a tremendous increase in the reflex tachycardia. So if we're talking about the heart rate, the maximum heart rate is increase is seen by the isoproterenol. Then there is the effect of the epinephrine. While if I talk about norepinephrine, there is going to be a fall. So this is norepinephrine, it is epinephrine, and this is isoproterenol, right? Okay, now there's another very important endogenous catecholamine, that is dopamine. So what happens to dopamine? Now dopamine, we'll be doing ahead. It has an effect on beta 1 receptors, dopamine, alpha 1. But on the heart rate, actually, it has very little effect. So you won't see much effect on the heart rate. Remember, for the dopamine, not much changes there. Okay, so now from this graph to another graph, very important, it is like the biphasic response and the vasomotor reversal of Dale phenomena that occurs. So what is first the biphasic response, and then we go on to the vasomotor reversal of Dale. Now, this biphasic response is seen when you give high dose of adrenaline. Okay, not the normal, high dose of adrenaline by the IV route. So you directly inject it into the vessel. So what you graph you will see is something like this. So there is a rise in blood pressure and there is a small fall in the blood pressure. The rise in blood pressure is because of action on the alpha 1. Remember the blood vessel we drew here. So alpha 1 and beta 2. Now when you give high dose, both alpha and beta 2 get stimulated, but the predominant effect which is seen is because of the alpha 1. So there is a vasoconstriction. So rise in what? So as now this is a maximum response till here that we see, and after this what is happening is, because you've injected adrenaline now, so now it is getting distributed, metabolized, and it is going to be excreted from the body. So slowly what is happening is the levels of adrenaline are coming down. So as the level of adrenaline is coming down, so you will see the effect on alpha 1 is also lost. So when very less amount of adrenaline is present, the only receptor which is most sensitive is beta 2. So the only effect that you see is because of the beta 2, and beta 2 causes fall in the blood pressure, and ultimately then it will go back to its normal level. So this is called as the biphasic, two phases, biphasic response. Now let's say this response is here. So again I'll draw this response here. Now after this you give a alpha blocker. So I am now going to inject an alpha blocker here. So let's say I am giving phentolamine, or I can give phenoxybenzamine. So I am giving an alpha blocker. So when I give phentolamine, wait for some time, and again I inject epinephrine. So let's say, so this is the blood pressure here, and now here at this point again I give adrenaline. So what do you think the response will be? So the graph that we get after this is somewhat like this, right? So only what is visible to us here is fall in the blood pressure. So there is fall in BP. There is no rise in BP. Why there is no rise in BP? Because your alpha receptors are blocked by the alpha blocker. So this reversal of the effect of this adrenaline after giving an alpha blocker, this is called as vasomotor reversal of Dale. This was seen by Sir Henry Dale. That's why the name Dale, vasomotor reversal of Dale. So it is seen when you give or adrenaline after you have given a alpha blocker. So here one of the previous year MCQ was that identify the drug which is showing this response. So see here the SPP is rising because of effect on the beta 1. The DPP is also rising. So probably the effect is mainly here alpha 1, otherwise it won't be there. So mean BP is rising, and I told you this would be the opposite to the DPP, though there is reflex bradycardia. So which drug which we just did showed these similar effects? Yes, it was norepinephrine. So this is any graph out of them can be given, and you are supposed to identify from that. Now moving on to the important uses of adrenaline. So if you have to do the important uses of adrenaline, just remember this simple mnemonic A, B, C, D, E, K. So A stands for, very important, it is a life-saving drug for anaphylactic shock. Anaphylactic shock. So we use adrenaline in 1:1000 concentration by intramuscular route, and you give 0.5 ml of this, right? You will keep on repeating till the patient improves. So this is the very important. The route of choice is intramuscular, 1:1000 and 0.5 ml. Now, as I told you, the effect is both because of alpha 1 and because of beta 2. So alpha 1 will cause increase in the blood pressure in this patient. It will also improve the laryngeal edema. While beta 2 will bring about bronchodilation, the patient will be able to breathe here, right? Very important. Now, in anaphylactic shock, the main mediator is histamine. But histamine acts on the H1 receptors while adrenaline is acting on the alpha 1 and beta 2 receptors. So, the effects that we see of both of them are opposite to each other. So, this special type of antagonism is called as physiological antagonism, when the two drugs, they are working on different receptors, but they are producing the response, the physiological response, in the opposite direction. So we say that adrenaline is a physiological antagonist of histamine. Okay, very important. Okay, moving on to the next use with the B is bronchial asthma. So not now, but epinephrine, not in the regular one, we use that, but epinephrine, it is used in treatment of brittle asthma. C, it stands for cardiac arrest. Okay, cardiac arrest. Again, we use epinephrine, but we use it in the strength of 1:10,000, and that is how we use it by IV route in the jugular vein. Because if you use the same strength, 1:1000, the patient will develop tachycardia, tachyarrhythmia, ventricular fibrillation, patient will die. So we never use the same concentration, always dilute it further. Alright, then we have D. D stands for duration of action prolonged. Of whose? Of local anesthetic. So it prolongs the duration of action of local anesthetic because we use adrenaline with them, which works as a vasoconstrictor. So it will decrease the, you can say, the systemic absorption of local anesthetic from the site where it is given. So increase the duration of action at that particular area. So it can be given in strength of 1:2 lakhs to 1:80,000. Then it is E. E is epistaxis. So we give compresses of adrenaline. Again, we can use 1:10,000. That is the ratio or the concentration in compression. And K stands for kalemia. So hyperkalemia. So it is also used in management of hyperkalemia. What are the other drugs here? The question is, other drugs which can be used for management of hyperkalemia. Yes, we can use insulin and we can use beta 2 agonists like salbutamol. So they can also be used for management of hyperkalemia. So these are the important uses of adrenaline. So moving on to next, dopamine, another very important drug which is asked in the exam. So because dopamine has a dose dependent effect. So all these dose dependent effects are important. Dose dependent effects. So when you give it as a lower dose, less than 2 micrograms per kg per minute, it acts on the D1 receptors and it leads to vasodilatation, especially of the renal blood vessels. So vasodilatation, especially kidneys, in the renal blood vessels. So therefore, it will improve the renal blood flow. It can help patients who are oliguric. Then if you use at the dose of 2 to 10 micrograms per kg per minute, then it also will affect the beta 1 receptors on the heart. It will increase the force of contraction of the heart. It will increase the cardiac output. More than 10, then alpha 1 receptor is also stimulated, and because of this there can be increase in the blood pressure. So mostly for therapeutic purpose we don't go beyond this 10. Okay. Then similar sounding drugs we have which can confuse students. Let's do them also. One is dobutamine. Dobutamine, and the other is phenoldiazepam. Phenoldiazepam. So dobutamine, please remember, it has a predominant effect on the beta 1 receptor, less effect on the other beta 2 and all, mostly predominantly beta 1. So for this purpose, it will be very good drug. It is used in congestive heart failure as well, right? And it is also used in case of cardiogenic shock, cardiogenic shock without hypotension, without hypotension. While dopamine is used in case of cardiogenic shock with oliguria. Otherwise, if there is hypotension, we'll use norepinephrine, right? So therefore we can. So dobutamine has this property. Then phenoldiazepam, it acts on the D1 receptors. This was a recent question, and it is used in case of hypertensive emergencies. Hypertensive emergencies. Side effects of beta 2 agonists, another high yield question. So what are the different side effects of beta 2 agonists? Remember 3 T's and 3 H. So first 3 very important side effect we have discussed already. This is tremors. Most common. Then the second T, if you give a higher dose or of beta 2 agonists, they lose their selectivity, and there are some receptors of present. What happens therefore is they can cause tachycardia. Now in heart predominantly the receptors are beta 1. There is some amount of beta 2 present, but that is one of the reasons. The other reason is when you give high doses of these drugs, then the selectivity gets lost. So they can also act on the beta 1 receptor. So that is tachycardia. Then the third one is that when you give it for a long period of time, then the patient will develop tolerance to this. H stands for, one is hypokalemia. That's why this is used in case of hyperkalemic periodic paralysis. Then it can also cause hyperglycemia, and beta 2 agonists can lead to hypotension. So these are the important side effects that you must know for the beta 2 agonists. Coming to the beta blockers here, very important are the cardioselective. You should know the names, which are the cardioselective beta blockers. So remember again a mnemonic, mean cab. So we have metoprolol, esmolol. It is the shortest acting beta blocker. And the longest acting also. Let's do longest acting beta blocker. We have nadolol. Okay. A is for atenolol. Nebivolol N, it releases nitric oxide. They can lead to vasodilatation. Then we have celiprolol, we have acebutolol, bitoxolol, bisoprolol. Bitoxolol is used in case of glaucoma, right? Bitoxolol. Then beta blockers with intrinsic sympathomimetic activity. So they have a partial agonistic activity. So we have a mnemonic co-PA. That means co-partial agonistic activity. So we have drugs like celiprolol, oxprenolol, pindolol, and acebutolol. This acebutolol, you'll see it is coming in all the classifications. So celiprolol, oxprenolol, pindolol and acebutalol. Then we have alpha and beta blockers, drugs which have both the alpha blocking as well as the beta blocking action. The most common we have is labetalol, and the other one is carvedilol. This is one of the most common. So because of the alpha blocking action, so they can have a vasodilatory effect as well. Antioxidant beta blocker, we have carvedilol. Then beta blockers with membrane stabilizing action. So can we have another mnemonic here? Yes, we can have lab map of the lab. So what is lab here? That is labetalol. Then we have metoprolol. Then we have, as I said, ACE is very common. ACE butalol. Then we have pindolol and propranolol. So remember these few drugs with examples. So for MSA, we remember LabMap. For ISA, remember CoPA and MeanCap for drugs which are cardioselective beta blockers. Uses of beta blockers, important, they are very important group of drugs for pharmacology. So for migraine prophylaxis, for thyroid storm, because they inhibit the peripheral conversion and also they decrease the sympathetic overactivity. The arrhythmia that we are really dreadful about, that they take care of, decrease the sympathetic overactivity. So all this is taken care of beta blockers. Essential tremors because of the beta 2 agonist, and hypertension with migraine because they are very effective in prophylaxis of migraine, for hypertension and migraine. So for all these group of drugs, we have most important is that is the propranolol. So propranolol is the one drug which can be used for all of this. Then moving on to the next one, which is hypertrophic obstructive cardiomyopathy. So in the hypertrophic obstructive cardiomyopathy, what is important is to know that there is increase in the contractility, right? So there is increase or hypercontractility, increased contractility of the heart. Increased contractility of the heart. So beta blockers, which is the drug that we use, is metoprolol. So it will decrease the contractions and therefore it will be helpful in this case. Another drug, a new drug for this, we have, it is called as mavacamten. Mavacamten. So what is mavacamten? It is selective cardiac myosin inhibitor. So it will inhibit the actin-myosin reactions, right? So it is helpful, right? So remember, for the first four we have propranolol as the drug, and for HOCM we use metoprolol. Aortic dissection, emergency condition, fast acting drug esmolol. Glaucoma, we have two drugs, one is timolol and the other is, we just now did the cardioselective one, betaxolol. So timolol is non-selective, betaxolol is selective for B1. But because timolol being non-selective, it is contraindicated in patients of asthma. So we can use betaxolol, but if a patient is of asthmatic patient, we do not prefer to use beta blockers. Though betaxolol is cardioselective, less tendency to cause asthma or aggravate asthma, but still we don't prefer beta blockers. But timolol is absolutely contraindicated because it is acting on both beta 1 and beta 2 receptors, because on beta 2 it will lead to bronchoconstriction. Then let's do the uses of alpha blockers. So for the alpha blocker uses, if it is benign hypertrophy with of prostate with hypertension, I told you prazosin would be the preferred drug. Prazosin. Scorpion sting, again the drug of choice is prazosin. It will take care of the laryngeal edema also because of this. Then pulmonary edema. Then pheochromocytoma, always remember for pheochromocytoma, we give alpha blocker followed by a beta blocker. So we can give drugs like phenoxybenzamine or phentolamine and then beta blocker, because if you give beta blocker beforehand, there will be alpha 1 left and it will be unopposed action of the catecholamines on the alpha receptors. So there will be further increase in the blood pressure. That is very dangerous and detrimental for the patient already, right? So already there is dangerous blood pressure. So we give alpha blocker followed by beta blocker. Then in the cheese reaction, clonidine withdrawal, we use phentolamine. So here we can take example of phenoxybenzamine. Okay, so these are the important uses of the alpha blockers also. Contraindications to the use of beta blocker, they are equally important. So let's do the contraindications. We have A, remember, B, C and D. So A is asthma and angina. Angina, which one? Variant angina. B is bradycardia block, AV block. Okay. C is, actually you can say, the congestive heart failure, which is acute in nature. We always give in compensated, never in decompensated. And then C can stand for constricted vessels, like in the peripheral vascular disease. D is diabetes mellitus. So it can lead to loss of the signs of the hypoglycemic symptoms and signs in these patients. So these are the important contraindications to the use of beta blockers. Let's do another important topic here, drugs for glaucoma. So drugs for glaucoma, remember, we have open angle and we have the narrow angle glaucoma or the acute congestive glaucoma. For the open angle glaucoma, prostaglandin F2 alpha analogs, these are the drug of choice. So open angle glaucoma, these are the drugs of choice. So these are your prosts. So we have letanoprost, bimatoprost, then we have travoprost. So what they do, they increase the uveoscleral outflow of these drugs. The important side effects or adverse effects we need to remember is increase in the growth of the eyelashes, which we call as hypertrichosis. Then this is the brownish pigmentation of the iris, called as heterochromia iridis. Then it can also lead to macular edema. So therefore it is contraindicated in case of diabetes mellitus. Remember, we do not use this drug if there is some case of inflammation like uveitis, iridocyclitis. Why? Because these prostaglandin analogs, these are pro-inflammatory. No, so therefore they will aggravate this condition. So never to be used in case of any kind of inflammation. Then the next group of drugs we have pilocarpine, physostigmine, and tarsodil. All of these drugs, they are going to increase the trabecular outflow, right? So pilocarpine and physostigmine, they are going to work via the M3 receptors. Pilocarpine is a direct miotic, it will cause meiosis. Physostigmine is going to increase the levels of acetylcholine, which will also act on M3 to cause meiosis. So they will increase the trabecular outflow. Now, netarsodil is a Rho kinase inhibitor, right? And this is going to relax the trabecular meshwork. Trabecular meshwork. Again, it is going to increase the outflow through the trabecular mesh, right? So these miotics like pilocarpine, physostigmine, so they can lead to brow aches and headaches. They can also lead to follicular conjunctivitis. Then, because of the ciliary contraction, they can cause retinal detachment. Now, nitarsodil can lead to conjunctival hyperemia. Okay, so then we have the next group of drugs which decrease the aqueous formation, and here we have the first group here are the carbonic anhydrase inhibitors. So we have the topical drugs like brinzolamide and dorzolamide. Okay, then IV acetazolamide. This is the drug of choice for acute congestive glaucoma. Now this is given along with mannitol. Then next we have apracnolide and brimonidine, which are the alpha 2 agonists, and dipivefrin, which is a prodrug for epinephrine or for epinephrine. Right. So these are the alpha 2 agonists. Now important here to know is that brimonidine, it is contraindicated in children less than 2 years of age because it leads to apnea of the newborn. Okay, and it also causes lid retraction. Okay, then we have beta blockers. Number third, beta blockers like timolol, betaxolol, levobenol and cartiolol. And fourth, we have the osmotic diuretics. Here we have mannitol that we give. Mannitol IV 20%. So we start this mannitol in acute congestive glaucoma, and alongside we also start acetazolamide. So all these drugs together you can remember with the mnemonic A, B, C, D. So A can be the which are the drugs which can act by the alpha 2 agonist. So alpha 2 agonist is A, B is beta blockers, C is carbonic anhydrase inhibitors, D is the diuretic. So this is another way in which you can remember these drugs. So these are the important drugs which are used for the management of glaucoma. Thank you so much.